Don't judge someone until you walk a mile in their shoes. It's an age-old adage which invites you to change places with someone, see the world through their eyes before you venture any kind of view about them. Simple enough to understand, but how can we bring it to life? Well, someone who's done exactly that is today's guest, Professor Stephani Hatch, Vice Dean for Culture, Equality, Diversity and Inclusion, and Professor of Sociology and Epidemiology at King's College London. Stephani's dedicated her career to making workplaces, especially the NHS, more inclusive by reducing discriminatory practices. And one way she's done this is by introducing 360-degree virtual reality headsets to managers and staff to allow them to walk in the shoes of racially minoritized staff in occupational roles. Her previous research has found that NHS staff members who were black or from ethnic minority backgrounds were more than twice as likely to experience workplace bullying and harassment compared with white British staff. This impacts mental health and ultimately will affect the care of those using the NHS. 639,000 days were lost in January 2025 alone through the consequences. So welcome to the We Society, Stephani. Real honour to have you here. I just want to kick off with these virtual reality headsets. Let's plunge in.
Sure. So
how do they work?
We've used them in two different ways. So one of the things we wanted to do is to, one, look at bias in clinical decision-making. And we were able to do that by using the sort of traditional virtual reality techniques, avatars, for example, and applying social theory. So we apply, for example, intersectionality theory. And that allows us to look at the person in the round in terms of their multiple social identities. So what the avatar allowed us to do was to sort of look past sort of traditional methods of having, say, vignettes of different situations in which a patient would come into a clinic and someone would, sort of see them, and you would have all these different vignettes. And if you multiply the number of times you would have to take into consideration different identities, you would have hundreds of vignettes. So with the avatar, you're able to do that. You're able to change the different identities right there and then. We then took a look at, during the pandemic, we had some additional funding for our study, and we're able to explore other ways of using VR. And that brought in the 360-degree film.
So I put on this 360-degree headset, and actually I can become a black woman nurse, effectively, and encounter the virtual reality as her.
Right.
So, and I then get what it's like.
Right. So that's the idea. So we really were wanting to take the emotional burden from staff, having to carry that, going into meetings, saying what it was like. So if you think about discrimination, we look at it in a couple of different ways. So one, about experiencing it, but we also look at witnessing discrimination as well as anticipating discrimination. So that headset not only allows you to feel what it's like to experience it, but it also allows you to witness it. So taking the qualitative data, the narratives of people's lived experience, and taking them to storytellers and script writers, and them creating these scenarios which actors carry out in these 360-degree films.
You're doing intriguing kind of social science research into racial discrimination in the workplace, aren't you? That's
Yes.
what you're doing. It's a really innovative way of doing it. And you're taking social science to really produce an evidence base. We can all make, and we do make, moral judgments about it, instinctive reactions to it. But no one gets underneath the surface of it quite like the way you're doing. It's extraordinary. Where is the evidence taking you, and what have you learning, and what do we know now that we didn't know beforehand?
I think it's really important with this last piece of work. It's, we've generating evidence. It's allowing us to understand more clearly what's at play in terms of, for example, empathy, and also exploring empathy as a concept within care. So really thinking about, what does that actually mean? Is that something that's useful in terms of enacting change and tackling things like discrimination, like bullying and harassment? Do we need to elicit empathy from managers and colleagues, from leaders, to actually see the change within NHS services? What I want to really emphasize here, too, is that we looked at the experience of discrimination and bullying and harassment from patients and their families, but also from colleagues and managers. And what we found is that it was from colleagues and managers that had the biggest impact on staff. And that sort of makes sense when you think about it being sort of a chronic exposure as opposed to a patient, that sort of acute sort of patient coming and going. And it was also attached to people working in teams. You want that level of trust. You want that level of collegiality that just wasn't there for a lot of staff from racial and ethnic minoritized groups.
Of course you want those things, but I mean, there's a real instrumentality in this, particularly in the health service. I mean, the way in which you diagnose an illness is about your capacity to listen to and ask the right questions of the patient. It's such a sophisticated business, actually, the human kind of interface between, a carer, a nurse, a doctor, a surgeon, a specialist, with each other. Otherwise, where do you get?
Well, that's how we got here, because we had identified in our Southeast London Community Health Study, which was a population study that started to alert us to discrimination in health services, both on the, part of the patient, but we also wanted to triangulate and look at the staff as well to understand all different sides of it, what's going on in that, like you described, complex social interaction that's taking place. And it is a complex situation, and it's one in which, it is very high up there in terms of our needs as people. So when you are ill, you go to the doctor, you do need that person to be asking you questions. You also need them to be taking seriously, the symptoms that you are describing very clearly, like pain.
And helping you, the patient, find the right language to describe it.
Absolutely. So we started looking at the literature, and, I came across a couple of studies from the U.S. that were describing using hospital records. So in this case, the sort of Kaiser hospital records, and that's important because there's very few in the U.S. where you've got these sort of hospital records that you can utilize for research purposes, or at least at that time. So what they showed was that the same individuals presenting with complex fractures and, there's undeniable pain there, right? They saw a very sort of stark difference in terms of racial inequalities and how they were then treated by the healthcare staff.
So, a racial minority person would complain of the same pain.
Yes.
They'd say, get on your bike, get on with it. It's it's only a muscle wrench or whatever, when actually it was a breakage or some such, yeah?
Yes. And so what struck me was in the discussion section of that paper, they talked about those from racial and ethnic minoritized groups. They gave these excuses for that behavior, saying they could have been drug seeking, they could have been, on and on. And then someone repeated this in pediatric services and found the same disparity. So it was really starting to think, okay, what could we do? And so I started that work in the Southeast London Community Health Study. This
was when, actually?
The Southeast London Community Health Study started in 2008.
Right.
And it ran until about 2015. There were 3 phases of that study. In the second phase, we looked at discrimination.
Right.
We were able to collaborate with Professor David Williams at Harvard, who has a brilliant measure in which it's basically very simple, asking the question about unfair treatment in various life domains. So various social life domains, whether that's in health services and housing and education, on and on. And then asking the person as a follow-up, what do you perceive the discrimination to be related to? And then they have a list of of different social identities. And overwhelmingly, we found a pattern of race and ethnicity coming first, Among those who had reported discrimination, race and ethnicity being the most salient, and followed that by social class. And then, the list goes on.
What's below that?
So gender, physical appearance, it goes on. And we made sure that, for example, in addition to social class, and we had other protected characteristics, so religion, we also added in migrant status as well. And that was very telling. So we started to see where we had, been thinking again about intersectionality, this idea of multiple social identities. One may be a little bit more salient.
Yes, just be clear. Intersectionality, you used that earlier on.
Yes.
We should just bone in on that to define it for our listeners.
So Kimberly Crenshaw came up with this theory around intersectionality, and it's really about, say, for example, myself. So I'm a Black woman. Those are two identities. I've got a racial identity, and I have this is a gender identity. And we just simplify it to that. I'm also a migrant to this country, to the UK. So there's three identities that really define a lot of the experiences that I have, and that I experience. There's this simultaneity of how I experience those. Now, one might be more salient in certain situations, but I'm coming to you as my whole person. I'm not, just one thing or another. It really allows you to think along those lines.
So, kind of defining intersectionality in the context of
discrimination experiences. So we started to think about that and really think about how, in particular, we needed to look at that at the intersection of race and ethnicity and migrant status, because we started to see these patterns emerging.
But what I find devastating about your work is you go on to kind of draw conclusions about kind of state of mind conditions, mental health, from which you then got extraordinary kind of loss of working days. I mean, in the introduction, I talked about 639,000 working days lost in January 2025. I mean, my God. I mean, this is kind of, it's about that. It's also about the kind of capacity to do your job as a health professional. What looks like being the 1/10 kind of above the surface of this iceberg of discrimination. Beneath it is 9/10 of really material and very worrying stuff.
Yes, absolutely. And I will say that one of the things that we were able to do very early on was work with those within the NHS who had already built a foundation of trying to understand exposure to discrimination among staff through the Workforce Race Equality Standard, for example. What we were able to do was take some of those, the very same measures that were used in the NHS Staff survey, put those into our survey alongside, measures for outcomes like mental health, physical health outcomes, as well as occupational outcomes. So looking at sickness absence, looking at, other indicators that eventually lead to, longer term loss of days of work, but also to poor staff retention. So people wanting to, completely leave the NHS because of these experiences. Yep. So in my group, in my health inequities research group, we utilize mixed methods, meaning we use quantitative and qualitative. And that's really important. So, for example, with the quantitative data, what we wanted to show was the extent of the impact of discrimination on health outcomes, particularly mental health, because we know from the wider body of evidence that discrimination has a pervasive impact on health outcomes, but particularly mental health.
And we're going to explore that more fully in a moment. I just want to kind of just stop, because as you've acknowledged, I mean, you are Black, you're a woman, and you're a migrant, and you're an American.
Yes.
And here you are working in the NHS, where you've been doing great work for 20 years. King's becomes your intellectual and academic home and the base from which you've been doing the work we've been describing up until now. Now, one element of that, which we should discuss, is tides.
Yes. I want to take you back for a second just to clarify. It was with UCL initially.
Okay.
Then I landed a job at King's at the Institute of Psychiatry, Psychology, and Neuroscience.
Right.
So it was there that I sort of had the opportunities to first do the Southeast London Community Health Study And those findings gave me the ideas for TIDES.
So what does an acronym stand for?
So this is tackling inequalities through looking at discrimination experiences.
So tackling inequalities, discrimination experiences,
Yes.
TIDES. Got it.
TIDES.
Now, this is quite something. Off you go. Tell us about TIDES.
So that started in about 2017, and sort of, again, utilizing mixed methods, but then bringing in the virtual reality as well as a methodology and sort of testing that out. That was really about, focusing on both the service user or patient, but also thinking about the staff themselves. And it was in the process of the first phase in TIDES where we really started to realize how little there was about the staff and their experiences. And why that's important is because it became difficult to talk about improving the quality of care of the population, for the service user, if we know that the staff themselves in many cases are unwell, and in part due to tractable problems like, exposure to discrimination, bullying, and harassment.
How did that manifest itself? What kind of stories did they tell?
I mean, there really are quite harrowing stories of sort of chronic exposure to this type of behavior. It's present in their, trying to do their job on a daily basis. It manifests itself and is evidenced through managers and colleagues doubting their abilities openly, humiliating them, shaming them on a daily basis, publicly in front of others.
A white doctor saying that to a black nurse, for example?
Well, it could be, nurse on nurse as well.
Nurse on nurse.
Yes. So they're talking about their managers, their colleagues. It's not always across the professions. Right. For example, one of the things that was fascinating was that the workforce race equality standard indicators for London, where you have high levels of diversity in terms of ethnicity, but what we found was that you have low levels of inclusion. So the way that manifested itself wasn't just about white and non-white. It got really complex in terms of what does it mean to have these diverse populations of people working within a service, but then not attending to ways in which you can, actively, make them feel that this is an inclusive, safe space for them. And really important here are two things that the res indicators showed, was that you've got a disproportionate number of those from racial and ethnic minoritized groups among the staff that are brought up for disciplinary hearings. And you've got a very stark inequity in terms of career progression. So you'll have, for example, a nurse coming in at band 5, a black nurse coming in at band 5, who 15 years later is still sitting at band 5, watching their white students basically be promoted above them. So that's actually the topic of one of our scenarios in the TIDES VR. You've got a nurse, a black male nurse, asking for help, asking for PPE from his manager. He's going through.
That's the protective wear for during COVID. Yeah.
Yes, he's just simply asking for what he should rightly have access to, and the white manager. And this is again based on someone's qualitative interview, and we heard this story again and again and again about access to PPE. We heard descriptions where there were whole teams where the white members of the team were allowed to work remotely, and those from racial and ethnic minoritized groups were made to work in person.
Hearing you speak, I mean, you're just, it's almost incredible, actually, especially the NHS, which prides itself on being a kind of inclusive employer, and the people who run it want to do good because that's the career
Yes.
they've chosen, you know.
Yes.
And yet it still manifests itself in the NHS.
Well, I think it manifests itself in a lot of organizations. This sector, the
I'm
NHS,
sure.
the health and social care sector are not alone.
If it's manifesting itself in the NHS, you're pretty sure it's kind of,
and I think that it's really
elsewhere.
important that we look across sectors, that we take a systems approach to this, that we don't just point the finger at the NHS.
Then what does it lead you in terms of remedies, in terms of what we do, what's to be done?
It is tractable. It's a tractable problem. Part of that is really working with those middle managers, those ward managers, but also making the leadership accountable. We want leaders to acknowledge the problem, number one, and then really think through what can be done in terms of the systems, the policies, the practices. And we have frameworks out there now. So, for example, one of the good outcomes that have happened over the last couple of years is the patient and care race equity framework, really spearheaded by Jackie Dyer. She was able to get this patient and care race equity framework going, and as of last spring, it's now mandatory in NHS trusts. And one of the things that it does is it looks at these issues and looks at, like, how do we address them at the trust level, but taking that systems approach, thinking about what are the other components. So, for example, getting CQC on board to start to think about if these things are happening.
The Care Quality Commission.
Yes, the Care Quality Commission. I got so many acronyms.
Well, don't worry. I'm sweeping them up as we go along.
Yes, thank you. So for where this is going on in a trust, who's being held to account? Because it's not only impacting the staff, but it's ultimately going to impact patient care. There's no way in which it can't if you've got a staff that is unwell.
What forces a revolution? Can we really solve the plastic crisis? And what was it like serving in the military as a gay man when it was banned? The new series of Life Solved brings you answers from the researchers actually working on humanity's biggest challenges, experts at the UK's University of Portsmouth and their collaborators worldwide. Each week, hear how cutting-edge research is changing the world, told in focused episodes that are perfect for your commute, your run, or wherever you do your best thinking. Series 15 opens with Craig Jones, a Royal Navy veteran and founder of the Fighting with Pride charity, sharing his experience of serving under the so-called gay ban and his fight for justice. The rest of the season takes you from the secret social lives of primates to the backroom negotiations at the Global Plastics Treaty, and reveals how women's clothing choices in Iran predicted the revolution years before it happened. 15 seasons of stories that matter, told by the people making discoveries that shape our future. Search Life Solved on your podcast app and subscribe today. This mental health issue has suddenly just moved up the national conversation. People concerned about the number of people who are, especially young people between 18 and 24, who are complaining of kind of mental health issues. I mean, amazing numbers. I mean,
yes,
1 in 4 at least. I mean, it's what that knock-on effect is for their kind of schools development, whether they ever get off benefit and all the rest of it. Is there more of this, or is the morphology broadly the same, but we're just more alert to it?
I think the jury's still out on that, and that's why there's a review going on right now, exactly around the prevalence of mental health.
Your instinct
disorder.
is what? Yeah.
My instinct? Well, I've worked over the years very closely with Professor Sir Simon Wesley, who's along with Peter Fonagy leading this review, and I think that there are some contributing factors that have not been unpacked. But then, of course, as a sociologist, I'm thinking about the broader social context and these sort of major social, and life events that have happened to us as a society. Most recently, of course, the pandemic. So with young people, it may be years before we fully understand what that rise is all about. It's a level more complex now with that occurring. So I really do think, I'm holding my judgment on what it is, or, because I do take the long view. Before the pandemic, you could also see that there was mental health in terms of acceptance of it and people taking it more seriously and being able to talk about it more and less stigma. Some work that I do in our ESRC Center for Society and Mental Health, we've got programs of work that are, focused on children and young people. We have programs of work, one in which I co-lead around marginalized communities. We've got another program of work on work and welfare. So we're trying to really think about that, but also not just focus on mental disorder, think about more holistically, what does that mean in terms of the experience of symptoms? So everyone has mental health. Our head is attached to our body. It really, it has an impact. We have all these social factors that can come to impact mental health. And certainly there are biological factors that impact mental health. It's quite complex, just as any, physical health problem is. But mental health previously really hasn't received the attention and the funding. And we've seen that shift. So that's also, something that is quite promising, looking at, key funders, the big funders, really focusing in on, what is going on.
And notably welcome, of course.
Yes, absolutely.
But I mean, when you began this exercise, it's almost a life work, I find. I mean, it did cross my mind. I mean, do you find worse discrimination in Britain than America, about the same or better? Pejorative words, actually. But I mean, just give us a sense of how serious is it here?
I think it's much more overt in many places in the United States. But race is a part of the daily conversation in ways that it doesn't often play out here. I think before the pandemic, there was some racism denial in this country, in the UK, that, it's sort of the tide shifted in those early days of the pandemic, and it was more a part of the conversation.
Yeah.
And you see it in the investments made. So NHS England, for example, funding the NHS Race and Health Observatory, which is, crucial, investment in terms of how we, try to tackle and understand what's going on within health and social care in terms of services, and focus on implementation and solutions, and, really understanding what's going on with the policies at the national level. So that's different. Whereas, in the U.S., you would have had those types of investments much more readily. But the difference I see is that the work that I'm able to do, I'm able to get it in the hands of policymakers in ways that I don't think I would have had access to in the United States.
That's good to hear.
It's very good to hear, because impact is really where the focus should be in this type of work. There's no point in continuing to just describe the problem. I really want to be a part of, what we do to change. And this is not going to be, sort of a linear path. And this is what I tell my research group and colleagues, and everyone who gets frustrated, we go 10 steps forward and then we, slide all the way back. We have to start again, or we've been at this for 30, 40 years. And I'm like, coming from where I came from, around social justice, around a civil rights movement, I know these things. If you think about how long it took to get a lot of these systems in place, you can think, then I start to get a little bit of patience with how long it's going to take us to undo these things.
Let's just finish on that note, not abruptly on this question, but I just want to get you to give our listeners some sense of what you think is being done, could be accelerated, the pace of change, what would good look like, say, 20 years out. Give us a sense of that.
Yeah, no, I have hope. I have hope on a number of accounts. I think that one of the things that gives me hope is the way in which research culture, and particularly in the social sciences, has shifted to center the lived experience. That gives me great hope. I have hope in that we are no longer just relying on those in higher education institutions for evidence. I think that there's a lot of evidence generated right across different sectors namely in the community organizations, volunteering community organizations, doing fantastic work that we need to respect. There's lots of work going on in communities that are now sort of we're partnering together to make that change.
And policies that are flowing from it, and behaviors that are flowing from it.
And you see it now. When I'm in a policy space, I am, surrounded by representation from, different sectors, representation from those with, lived experience, expertise that are bringing their, making these things come to life. So, making sure that we remember that there are people in those numbers.
Professor Stephani Hatch, we have to stop, I'm afraid. We're out of time. Been a delight talking to you. Also hearing how you're using social science and how, as a fellow of the Academy of Social Science, you're using social science to affect change. Thank you so much.
Great. Thank you.
Thank you so much for listening. The We Society is brought to you by the Academy of Social Sciences in association with the Leverhulme Trust and the Nuffield Foundation. I'm Will Hutton, the producer is Emily Finch, and it's a Whistledown production. If you haven't already, please subscribe to the podcast, leave a comment, share with your colleagues and friends. And thank you so much for listening.